Hello friends, welcome to Creative Medicine. In this lecture, we will learn about
Potassium sparing diuretics. Potassium sparing diuretics are mainly of two types. One, we have aldosterone receptor blockers. The aldosterone receptor blockers are spironolactone, and we have eplerenone, and then we have canrenone is present as aldosterone receptor blocker. Then we also have epithelial sodium channel blockers. These epithelial sodium channel blockers include amiloride and triamterene are the epithelial sodium channel blockers. We also have these potassium sparing blockers which are seen here are actually sulfonamide derivatives. Most of them are sulfonamide derivatives. These are actually slowly acting drugs and these are weak diuretics which are seen. So, mechanism of action of potassium sparing diuretics. These potassium sparing diuretics, number one, they block aldosterone receptors. Now, the aldosterone receptor, if this is the one, here there is aldosterone receptor. The aldosterone receptor is mainly present near the blood side. Okay, this is the blood, this is the tubule or urine. Okay, this is the tubule. Now aldosterone receptor is blocked by these drugs, aldosterone receptor blockers. So when this aldosterone receptor is blocked, here normally we have sodium reabsorption occurs, and water will get reabsorbed, and also chloride will also gets reabsorbed. Sorry, normally sodium gets reabsorbed, potassium is secreted, and even water gets reabsorbed. Okay, so in due to aldosterone will activate the reabsorption of sodium and water and excretion of potassium. But now when you block this aldosterone receptor, so the aldosterone will not act on these channels, and as a result there is no absorption of sodium, there is no absorption of water, there is potassium is not secreted. So as a result the patient here will have increased sodium in the blood because it is not, sorry, increased sodium in the urine because it is not reabsorbed. Because sodium is not reabsorbed, there is increased sodium in the urine, thus resulting in the patient will present with hyponatremia. Similarly, there is the patient will present with hypovolemia, and then the patient will also present with hyperkalemia. Okay, now because this potassium is not secreted, so this is present in our body causing hyperkalemia. So if you see the pharmacokinetics of these potassium sparing diuretics, these are actually these drugs are well absorbed. They also have first pass metabolism is high. Then triamterene, the drugs like triamterene we have, and also spironolactone. These triamterene or spironolactone are actually avoided in hepatic failure. We should not use this triamterene and spironolactone in hepatic failure. This spironolactone is actually a prodrug. The prodrug of spironolactone is canrenone, and the half life of this is around 24 hours, and this will also these will accumulate in renal failure. So the drugs which can be given in which are avoided in hepatic failure are triamterone and spironolactone. These potassium sparing diuretics will mainly accumulate in the renal failure, so they also cause side effects like hyponatremia, hypovolemia, and also hyperkalemia, and they can cause sulfur allergy also.
thank you and thank you for watching.